I would now invite Dr. V. Surya Prakash to come and give his lecture on chronic total occlusions, rationale for CTO recanalization and techniques. Dr. Surya Prakash, please.
So this is a rationale and techniques for CTO interventions. See, we have a program from 2006 to 2011. All my colleagues who are working with me for so many years contributed a lot to this CTO program. We had a lot of association with the Japanese colleagues who I think are the masters in the CTO, and something translated to us from them. I'm really grateful to them. We do annually this program of CTO course under the banner of CACTO. And you see what exactly the rationales. You see there are changing times. So the indications also change with advancement in the technology, the skill of the operator, and so many things. So the indication definitely change. For example, I never used to touch the patients about 75 years old, symptomatic patients also, keep an optical medical therapy. This is one patient, female, recently, I have to take up, in spite of the optical medical therapy, patient is on, we have to open the RCA mid-CTO. We have done this procedure in 25 minutes time, and mostly I attribute this to the hardware, what is available nowadays. That's why the radial approach, and what is previously never thought of is being done. That's what I want to show from this slide. And our data from the 2006 to 11, we had around 276 CTOs done, out of which around 72 are antegrade approach, and around 4 are the retrograde approach. We succeed only one retrograde approach, and maybe the advancement will do more as per the indications. And usually we do 25% of the cases we have done a CT angio, and the access is mostly femoral. Even though we are a radial operators, 99% of our cases, the complex CTOs, I always prefer a femoral approach. You see, mostly the guidings are amplage guidings we prefer, even though we know they produce dissections, but they give definitely good support, as you've seen in the last case. And also, the EBU and the launcher catheters for the left are very useful. The wires I have seen, the tapered, non-tapered, coated and non-coated. Simply I can tell like this. And the latest wire is the CN wire, which is very useful for the retrograde technique. And among the latest advancement catheters, what we have seen is the Corsair catheter. This is a very useful, trackable, flexible microcatheter type, a channel dilator. You need not dilate with a balloon, the septal dilators. It is available in India now. And the balloons, what we mentioned last time, we have seen the Acrostack Thermo. And the advancement is Falcon balloon, which is available 1 millimeter, even 0.85 millimeter balloon also available. And this is all the data what we had. We had 2 LMC dissections during the procedure and 1 donor artery dissection. We have never lost any patient, but we had a couple of complications which we can manage it with prior planning. And our success rate is around 89.5%. And as you see, the symptom control is important, and to improve the LV function is important, and the survival is definitely proved after the CTO interventions. So there are certain slides which show that long-term survival, the LV function at 3 years follow from the baseline in a case where success is there, failure is there, a lot of difference p-value is significant. And also, the predictor of LV function improvement is based on the baseline LV dysfunction and the distal microvasculature. This is very important. And there are occasions where re-occlusion, the LV function has fallen down. So evidence of viability has to be seen, there is no doubt. When the patient is very symptomatic, large vessel, we open it. Otherwise, we see the viability. But most important, we have seen is the cardiac MRI. I definitely express my thanks to some colleagues in the care hospital who regularly send there for the cardiac MRI. They have given a very excellent reports, and we have done the CTOs, and patients are doing very well. And the simple test is the ECG, poor R wave in the ECG, and sometimes we use the Dobitins test also for the. And the long-term survival with CTO PCI is a lot of series are there, success versus failure. And the long term, the p-values are significant in most of the studies. And you see, this is very important. The survival benefit has been seen in LAD CTO intervention. But it's not that you should not do the circumflex RCA. They are very big vessels. Distal vessels are very good. You feel the success rate is more, it will benefit the patient, you should go ahead. But it is proven in one of the studies that LAD CTO benefits improvement in the LV function. And the CABG need also will come down with all these trials, whatever written here. The CABG need in the future has come down with CTO interventions. So it is not dangerous. If you compare the acute complications in non-CTO intervention and the CTO intervention, it is not much difference. These are all the encouraging things. And the drug-eluting stents. You can use now long drug-eluting stents and the research registry and the Milan registry, present trial. There are so many which really proved that the DES is beneficial in the CTO interventions. There is another ongoing trial by Dr. Park in Korea. So this is a decision CTO drug-eluting stents, the ongoing trial. And now it is proven it is not very dangerous. Low procedural success, the improved now success rate and restenosis rates have come down. So there are some trials which have proven all this. So, but I can clearly tell there is no randomized powered hard clinical endpoints comparing the optimal medical therapy and the art of CTO recolonization. There are certain predictors of procedural success you should assess before attempting this. Most of you know about the length, the tapered, non-tapered, antegrade flow, osteal occlusion, all these things. But I feel most important is the bends in tortuosity and the calcification. In our cases of large number, which is one of the largest volume in the country now, I can confidently tell the bends and the calcification really made us to differ in certain cases. And if we got associated CS morbidity, then surgical like left main and valvular disease surgery is option. You see here, this patient long LAD disease, and but it is not an issue now. Length is not an issue. You can see the vessel is open nicely. And second thing is tapered, non-tapered. Actually, if you see this vessel is a tapered thing, but when we see this, the CT coronary and angiogram did not show any distal vessel. This is a very poor sign. Even you feel the wire is in place, everything we checked, but this is not, this success is not good. And bends and tortuosity again, there are so many bends in this. These cases are, the failure chances are more. As you see, even if you try antegrade or retrograde. And these are the cases, we tried the retrograde technique with a Corsair catheter, and we entered the SVG graft in some of these cases, but we felt the SVG graft opening retrogradely is sometimes dangerous. And the thing is that there is an acute tortuosity, if you see in the last thing, which made us to defer this case. There is acute tortuosity. Even the Corsair could not negotiate. So bridging collaterals have seen the success rate now definitely improved unlike previous days. And you see this. And one of the important thing is it's not a major issue nowadays. Bridging collaterals I've seen in the last case also. Flush occlusions, very risky, and you should have a CT angio in this. And retrograde technique with IVAS guided is very important in this case. And circumflex CTOs and left main and circangulations, these are very important. These are difficult cases. A newcomer, new entrant should not attempt these cases. And the side branch is, they say, a bad predictor, but side branch after the occlusion, immediately or at the lesion, they are useful actually. You can take advantage of that. The instant restenosis of few years duration at the ostium, these are the worst cases we are not supposed to attempt. And a diffuse disease, this patient had a diffuse disease and the patient had a RCA total occlusion. So this patient who had under CT angio, actually the segment where we have to cross looks soft, then we open this vessel. And, but ultimately what happened is, this patient's disease, you see how much benefit the patient got in this, I don't know. Because long diffuse disease, we could not do anything after opening for 2 hours. The procedures like antegrade, retrograde, IVAS guided, parallel wire technique, side branch, we will discuss on the coming slides. And the most important thing is the parallel wire technique. If you cross with a single wire, it is fine. And if the parallel wire technique also fails, sometimes we have to use IVAS guided. Sometimes the star technique and retrograde techniques are useful. And CT is useful for the entry point to know how long, how much length, how tortuous, what strategy you should have, calcification, what is the projection angle, bends and tortuous. This way CT is very useful. We see here long calcification, bends in the area. So CT angio is very useful some of the catheters. As explained, the catheters, amplified catheters, EBU, Lancer catheters, sometimes mother and child technique are very useful. The hardware 7 French, 8 French are useful, not 6 French unless you do a radial procedure. And to cross the hypercoat wires, run through plastic jacket wires, fielder FC, XT, but most important nowadays is the Cyan wire, which is a very trackable, flexible wire available in India. The Conquest Pro or Confluenza wire, the toughest wires, 12 grams and 20 grams is there. These are the wires, they differ in the tip strength, that is more important. The trackability with the hydrophobic or hydrophilic coating. These are the two important points in these wires. You see the miracles, all of you are aware of these miracle wires, 3, 4.5, 6, 9, 12. And balloons and catheters, as we discussed, but more important the Tornus catheter. In the last case, if we are not able to cross with a balloon, the ideal is to use a Tornus catheter. Another is the IVAS guided. IVAS is very useful in complex interventions. That's why you choose 7 French or 8 French. Side branch technique, you can put the IVAS in the side branch and see in the false lumen, dilate with a 1.5 balloon, keep the IVAS in the side false lumen and check the true lumen, and you can enter the second wire in the true lumen. And the device selection also IVAS is very useful. This is the parallel wire technique, where this case you can easily see this patient had a very CTO failed at 2 places. And you can do it simply by doing the parallel wire technique, and the patient had a very good result. It's done very recently. So these are Tornus. The lowest profile is 2.1 French. It's a tapered thing and a braided thing, and it tracks along the tough resistant tracks, and steel braided thing. It's a very supporting catheter. You can even exchange the wires also. And why retrograde? Retrograde we see nowadays in anatomical difficulties when antegrade is failing. And tortuosity, calcification, side branch, not a major issue in retrograde technique. There are so many collaterals we use, but LAD to PD, PD to LAD is the most common collateral what you use. Here you can see the case. Like you see here the collateral for the LAD is coming from the PD. And here you see the collaterals coming to the LAD from the PD. So these are the collaterals commonly we use. And most important thing is multiple views, as you see in the last case, orthogonal views, simultaneous and contralateral injections, choose check hardware, and CT angio is very good. And keep always covered stents, very, very important. Coils for septal perforators, check the ACT keep more than 250, and snares are very important. And 4 o'clock is not the time for CTO. Early hours, fit operator and a fit patient. The success rate is more in this. And other thing is, these things I discussed. And in the reverse retrograde technique, cord technique, you know, you keep the balloon on the retrograde wire, dilate it, create an intimal, subintimal track, pass the antegrade wire. They reverse doing a balloon on the IVAS guided antegrade, and passing the balloon is the reverse cord. Here we have done the case with a Corsair, the osteal lady with the Corsair wire and retrograde technique with IVAS guided. The problem in these cases is, you are left man, you should prepare for stenting. You can do a bifurcation kissing stent. If you want a good result, you have to have prepare for left man. So predictors of success, it depends upon the location of the collateral, and use the rotational views. You can limit the contrast. Super selective injection, Dr. Sarchandra has suggested that. And sometimes you can try with the individual collaterals also, but the success rate is less. And other thing, shaping of the wire, Dr. Goel has shown you the tip of the wire, 1 to 2 millimeters, 45 degrees, and around 15 degrees proximally. It makes you the trackability of the wire in the CTO segment. And other thing is the two methods. It's not the rotation. I strongly differ in the last case. It is the penetration. Distal cap you have to penetrate, always remember. And caution is new entrance not to attempt retrograde technique. Hemopericardium you can manage. Cardiac tamponade you can reverse with heparin pericardiocentis. And septal perforation you can close with a coil. And osteal dissections you may need a stent. This is one case where we are doing the antegrade this thing. CTO, real CTO, 5 years duration. We have done everything, but we lost the left main. The left main is dissected.
I think Surya Prakash, you finished your time. That's the reason probably.
So we have to stent this patient left main also. And this is one area where we had a donor dissection in the retrograde. We have to stent the donor artery. You see, finally you have to stent the donor artery in this case. You should prepare for all these eventualities. There is a star technique. You can see sometimes you can enter the false lumen to true lumen and do this stenting is submittable. But it is done in the peripheral vascular disease. Now we are able to do in coronary also. The 6 months follow-up, this patient, the stent is patent. There is no subacute thrombosis. So there are some new options, and most important thing is a compromise between the symptoms, technical success, complications, operator experience. You should have when you attempt the CTOs. And really, these people, Japanese, contribute a lot to the CTOs in India. And nowadays, almost all the centers are equipped with the hardware, started doing the CTOs successfully. And I sincerely invite you for the forthcoming Indo-Japanese Club organized by us and the CACTO 3 in the 2012. Thank you.